This meeting is now being recorded.
Well, welcome. Good evening. My name is John Furman. I'd like to welcome you to the EDS Awareness Educational Webinar. Before we introduce our speaker, we'd like to give an overview of our free program for those attending for the first time. So we'll go over who we are, what is our program, some upcoming events, introduce our speaker for this evening, Dr. Ronald, Jaekle, and then we'll have a Q&A session. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 75 groups to date. Each group is given their own free website with a link from the directory and map. We received feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring speakers to you through the free EDS Awareness Educational Series. We meet every first and third Tuesday, typically at 7:30 p.m. Eastern Standard Time. All the programs are free. The meeting announcements and, when possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. The store is the only funding for this program, and it usually covers our monthly web fees. Please visit our store and check out the helpful products that we sell. Just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice and it's not to be considered advice. If you are having medical problems now, please call 911. Always consult your doctor before making any changes to your treatment.
Wanted to make you aware of our upcoming webinars. Our next webinar is May 19th, and we will be pleased to have a presentation by Dr. Brad Tinkle. Dr. Tinkle, as many of you know, had been at the Cincinnati Children's Hospital for many years, and now he is the Medical Director of Clinical Genetics at Advocate Children's Hospital in Chicago. And he's going to do a detailed presentation, and you won't want to miss this one. It'll be really great. This, again, is on May 19th, and you can read more information on our website about that. Just a reminder for EDS Awareness Month in May that the EDS shirts are available for $10 each, and you can find those at bodysupportstore.com. For those attending live tonight, there will be an opportunity for Q&A after the presentation. Add your questions at any time during the presentation by clicking on the Q&A icon at the top of your screen. After typing in your question, click the orange button to submit. Our speaker tonight is Dr. Ron Jaekle, and his topic is pregnancy and Ehlers-Danlos syndrome. He's an OBGYN affiliated with Christ Hospital and Cincinnati Children's Hospital Medical Center, as well as a professor of obstetrics and gynecology and director of the perinatal services and he's a medical director of the Perinatal Treatment Center at the Center for Women's Health at the University of Cincinnati College of Medicine. And Dr. Jaekle has spoken at the EDNF conference a few years ago about pregnancy and Ehlers-Danlos syndrome. And with that, I'm going to extend a warm welcome to Dr. Jaekle. Thank you so much for helping us tonight with this very complicated issue.
Well, and thank you for letting me have the opportunity. I will admit that I'm not the most gifted speaker to community groups, so when you look at my slides, you're going to say to yourselves, these slides are for docs and residents and medical students, and I apologize for that. So I'll kind of zip through, but the reason I didn't change them too much is because there are some points that I want to pull out and bring to the front. I'm a fairly interactive speaker. This format isn't quite as interactive as I would like it to be, just because if you guys need to interrupt me, I will be watching the 82 different ways I can look for you guys to interrupt me, and I'm happy to be diverted and answer a question. But at the end of this, I'll have plenty of time for questions and answers.
Great. Thank you so much. And I am glad you have the more detailed information in the slides. I think people will really appreciate that depth of information.
So how about I start?
Let's go.
So the goal here is to kind of overview the subtypes of EDS. I know that I'm assuming just watching the now 18 people logged into the conference that you guys all know your diagnosis, but just because you know your diagnosis doesn't mean you necessarily understand the nuances between others. So I'm going to run through that real quick, and then more importantly, go back and talk about just what happens to everyone when they become pregnant. Because today I was arguing with our cardiologist about a patient who's got heart failure, and he was talking about her as if she wasn't pregnant. And I finally said, stop, she's pregnant, it's totally different. And then we had a meaningful discussion about why her testing was different. So it's always good to know what happens to your body when you get pregnant. But then we'll talk a little bit about the complications and then some delivery and recovery issues. So there are 6 major pictures of EDS. And the challenge is that there's a ton of overlap. I'm sure, as you guys all know, it's sometimes challenging for your docs or for your care providers to be able to specifically, just based on your clinical picture, tell you specifically which subtype of EDS you've got. The reason for that is a lot of them have skin hyperextensibility. The joint hypermobility is not just confined to the hypermobile group. Tissue fragility is a extraordinarily troubling and common problem. And then I've yet to meet anyone with EDS who doesn't complain vociferously about how hard it is to heal from wounds and how easy it is to wake up with a new bruise that you don't know how or where it came from. And so ultimately we end up falling back to the new, elegant genetic testing that allows us a better opportunity to subdivide exactly what the diagnosis is. So the classic EDS, which back in the olden days was called type 1 or type 2, is a abnormality of type 5 collagen, and it's an autosomal dominant condition. What that means is it only takes one copy of the gene for the disease to show up in an individual. So obviously if you have type 1 or type 2 classic form EDS, then each of your children has a 50-50 chance because you're either going to pass the gene on or you won't. The way it gets started is there are going to be families where nobody has a diagnosis, and then all of a sudden it's there. Well, on any given time that you do meiosis, the cell division to make an egg or a sperm, about 1 in every million genes undergoes a change. And so there's an opportunity just during the rebuilding of the chromosomes for division for a spelling error to come in place in that gene. And so that's how it gets started. And then because it only takes one copy, it's much easier for it to be passed on. The challenge with classic type is really more about things not staying where they belong. And so mitral valve prolapse, or the heart valve on the left side of the heart gets floppy, which is probably not surprising. From a gynecologic standpoint, we know that patients with classic type are more likely to have problems with their female parts falling out, organ prolapse. During pregnancy, we worry a lot about ruptured membranes. The collagen that creates and stabilizes the amnion, or the bag of water, is less secure, so there's more risk for ruptured membranes. But the other intriguing thing is that membranes are not actually watertight. So when we talk about ruptured membranes, it's really a bit of a misnomer, because if you take the bag of water after the baby's been born and you just support the membranes and put water on top, within just a matter of time, the water is dripping through the membranes. About 30% of the amniotic fluid that changes every day goes across the membranes directly into mom's bloodstream. So if it's not watertight, then why doesn't everybody leak fluid? Well, that's really where what we call the decidua, mom's tissue, creates a barrier for pathways of fluid to go from the membranes out to the cervix. And my suspicion is that the reason why patients with Ehlers-Danlos have so much more, such a more common experience with ruptured membranes, is that the underlying layer, the decidua, because the collagen's not as dense, not as strong, is more prone to being channeled to allow the fluid to find a way away from mom's bloodstream and towards her cervix. If you guys are into really esoteric and fancy genetic information, it's the collagen 5A1 gene. It's on the 9 chromosome. Q means it's on the long arm of the chromosome, and this is the part of the chapter of the long arm where you'd find it. Type 2 is, as I think those of you that have it know, that that's typically the milder of the two classical types. However, only about 50%, 40 to 50% of patients with a clinical diagnosis of classic type EDS will actually have this genetic abnormality. There is another abnormality that can cause it, and that is a progene, or a longer form of the gene, that will be abnormal in another 10%, and then the balance will have an actual insufficiency of this part of the gene. So there's a variety of different ways for one clinical condition to show itself. So this is not like, for example, cystic fibrosis, where it's a single gene, and so we know to look in that gene area. But like cystic fibrosis, it's all about the spelling errors. And so we know there are over 100 genetic spelling errors that can be associated with cystic fibrosis. For classic type EDS, there are a variety of abnormalities in the genes, and there are several different genes involved in the disease. The hypermobility type used to be called EDS type 3, and it's really a clinical diagnosis. The reality is that there's not an easy gene availability, and the docs that are conversant with it are able most of the time to make a diagnosis just from the way things are. Now, the key there is there are other, obviously, medical conditions that mimic the disease. So hypermobility type ultimately becomes a diagnosis of exclusion. We've ruled out everything else, and so this is our diagnosis. The joint findings are the primary issue. I think everybody with hypermobility type recognizes how easy it is to twist an ankle or sprain a knee. Before we started this, because I'm not an orthopedist, I was asking the question of whether this is the micro tear, micro injury around the joint versus real actual damage to the tendons and ligaments, and I'm going to probably go spend some time with ortho tomorrow to get that question answered for myself. The vascular type is one of those obstetric conditions that actually put fear into me, and the reason for that is it can be a really bad actor in pregnancy. It doesn't have to be. There are certainly a number of case series that suggested that it's not uniformly lethal, but boy, when it causes a problem, it really causes a problem. It's an abnormality of the type 3 collagen, another one of these pass-onable conditions because it only takes one copy of the gene. I just remembered it. My pen is not showing up on your screen. Now, do you guys see it? Well, you can't tell me if you see it. So vascular markings, it can be seen through the skin because the vessels are so distensible. It creates an opportunity for blood vessel tears, intestinal tears, and then much more common, actual tendon tears. The challenge with this is that the challenge with this is that it really does result in, unfortunately, a change in lifespan. And so when we talk about pregnancy for these patients, it's not just about how the pregnancy goes, but it's about life planning going forward because of the impact of the disease. Type 6 is now called the kyphoscoliosis type. It's different than the rest because it requires 2 copies of the gene to create. So it's autosomal recessive. Mom's got to have a copy, dad's got to have a copy for it to be passed on to an offspring, to one of their children. This is an abnormality of the lysyl hydrolase gene PLOD1. It's on the short arm of the number 1 chromosome. And this actually creates a condition that looks a little bit like Marfan's. Marfan's is another genetic condition that's associated with vascular and joint abnormalities. And like Marfan's, it's associated with a very high risk of having the aorta dilate and then tear. The other intriguing thing that I found when I was doing my homework for this talk is the common problem with retinal detachment. We see retinal detachments not every day in labor and delivery during pushing, but we see them probably a couple of times a year, and I'm now going to probably begin to wonder if there's an association with retinal detachment and EDS for patients that otherwise weren't diagnosed. Type 6 is another type 1 collagen abnormality. This has some more variable genetics. So some patients, it seems like it takes 1 copy of the gene to cause the disease. Other times it looks like it takes 2. These patients are typically shorter, more likely to be associated with congenital skull fractures. I will admit to you, we don't really make the diagnosis of skull fractures during ultrasound. I spend all day long in the ultrasound unit, and I can only count on one hand the number of times we made a diagnosis. So congenital skull fractures are those babies that are born, and at their first evaluation by the pediatrician, lo and behold, they've got a skull fracture. And it always seems like it had to be something to do with the labor or pushing or how we got the baby delivered, but it's really probably more just an issue of the fact that the baby was going through a space that was small. I mean, that's called the birth canal, and so it's not anything that you could have done differently. And the nice thing is, most congenital skull fractures, because they're not traumatic, they don't really press in on things. So we can, most of the time, we don't have any of the associated problems that adults have when they get skull fractures. Congenital hip dislocation is a very common issue. So specific diagnosis is what I find my patients want. They want to know the answer. They don't want a list. I'm obligated to create a list in my mind, but ultimately you as the individual want an answer. So we have to really work on it. And because it takes work, my personal bias is it's always best to see your maternal fetal medicine specialist and or genetic counselor before you get pregnant. That way we have plenty of time to get answers. We can do the genetic stuff. Many of the genetic labs don't see the time pressure that we see in pregnancy. They figure they got all the time in the world. They don't really recognize it's 280 days into pregnancy. So they're not in the same rush that you would be as the patient or I would be as the MFM. So do this workup before you get pregnant so that we know if there's anything we can do during pregnancy for a prenatal diagnosis or anything we need to modify as you go into the pregnancy. Type 6 is really not necessarily a genetic diagnosis because it's looking at the enzyme activity, and that can be tested and looked at in amniotic fluid with an amniocentesis. So this is the one type that actually lends itself nicely to prenatal diagnosis, assuming you do the amnio early enough that you have time to do the assessment. I don't know if you guys have ever actually looked at the bag of water that the baby hangs out in for 280 days, but it literally looks like a little thin Ziploc bag, maybe about that thickness. But if you blow it up, these are all the layers that you've got between the amniotic fluid at the top of the screen and the outside of, or the muscle of your uterus on this end of the screen. And interestingly, while type 3 collagen is in all of these different layers, you can see that there's a distribution of the other types of collagen that it's not consistent from one layer to the other. So you've got an opportunity, depending on which collagen type is abnormal, that you may have abnormalities at different layers. So I just thought I'd throw that picture out there because I find it kind of fascinating. A bag that looks no thicker than a Ziploc bag has this much complexity to it. So let's talk about pregnancy. During pregnancy, you increase the amount of blood in your body by about 40%. So you go from 5 liters of blood to 7 liters. Think about it, that's what? Roughly 5 pounds of your pregnancy weight gain is just liquid in your blood vessels. And it reaches its top at around 30 weeks. So between 18 weeks and 30 weeks is when you begin to feel your blood system, your blood vessels feel that change in the amount of work that they're having to do. In order to push this 40% of extra blood that's in the blood vessels, the heart's got to work harder. So the cardiac output, or the amount of blood pumped per minute, goes up by 50%. It's not just a little increase. It's a big increase to help provide all that extra blood supply that you need to feed the placenta. Everybody's pulse goes up a little bit. Even those patients that just got done running the pig, the Flying Pig is a marathon here in Cincinnati, and so they're running around with pulse rates in the 60s. The reality is those patients with pulse rates in the 50s and 60s still have a 5 to 10 beat per minute increase in their pulse. If you're out of shape like I am and your pulse rate's in the 80s, then you're really looking at a 16 beat per minute increase by the time you get to the end of pregnancy. But the cool thing is each heartbeat increases the amount of blood pumped per heartbeat. So it's not just an increase in pulse that gets the output increase, but it's also the heart pumps more efficiently. And this increase in pump efficiency reaches its peak in around 32 weeks. In order to have all of this extra room, you have to have your blood vessels that get stretchy and make extra room. So there's a thing called venous capacitance. The vein side of your blood system is where all your extra volume sits. The problem is those vessels happen to be the least supported. That's why they can stretch. Not as much muscle, and if you've got less than optimal collagen, this is why bruising is such a problem during pregnancy and why the blood vessels seem to be more fragile during pregnancy. by the time you get to your due date, about 15% of each heartbeat is directed right at the uterus to feed the placenta. So you really do redistribute. The cool thing about physiology is that your heart is designed and your blood system is designed to preferentially send a boatload of blood to a structure that before pregnancy is the size of a lime. Your kidneys are doing more work, and the thing that becomes problematic for our hypermobile patients is this supine hypotension syndrome. POTS and postural orthostatic hypotension is a day in and day out challenge for patients with hypermobility syndrome. If you add to that the fact that when you lay down flat on your back in pregnancy, your uterus pushes on the vena cava and cuts down on the blood supply back to your heart, you can understand that it's sometimes confusing whether your symptoms are the supine hypotension that everybody who's pregnant experiences, or is this just an augmentation of the POTS that happens when you're not pregnant. Progesterone relaxes the blood vessels and relaxes smooth muscles. It also makes your uterus relaxed and keeps it from contracting. The challenge for that, though, is that that's all of this that goes on increases the flexibility and decreases the integrity of your joints. So pregnancy is counterproductive for knees, ankles, shoulders, etc. Relaxin is a hormone that kind of helps keep the cervix in place. With pregnancy, everybody knows that they seem to get more heartburn. They don't necessarily always understand why. As your uterus grows and pushes everything up to the top of your abdomen, your stomach gets caught between the uterus and your diaphragm. That pushes the junction of the stomach, the gastroesophageal junction, which is the GE in GERD, up into the diaphragm. So every breath, it pulls the gate to the stomach open and creates the opportunity for stomach acid to give you heartburn in your esophagus. So what I tell patients with bad reflux is if they eat standing up, they find that their stomach falls back down into their abdomen, so there's less opening, and heartburn gets a little bit better. Sacroiliac joint and pubic symphysis mobility is a huge problem. It's a great problem to have if you don't have EDS, because by increasing that flexibility, you create a much more open pelvic inlet for the baby to come through. But when you've already got excess mobility, add pregnancy to that, it really does create some challenges. And then stretch marks in spider veins and varicosities. So what we do in our office when we have a patient with a known diagnosis of EDS is obviously we see him and talk to him, and we want to make sure we get the initial evaluation done. Most patients with hypermobility syndrome will not have a problem with their aorta, but because we know that pregnancy creates challenges to the aorta, we do try to make maternal echocardiogram part of the evaluation for anyone with EDS. And those patients with an aortic root above 4 centimeters, unfortunately, are counseled that their pregnancy may put them at greater risk for safety. And then, depending on the type of EDS, we'll do carotid and abdominal aorta assessment, looking for evidence of aneurysms. We like to look at aortic Doppler analysis, looking at peak velocities and the waveforms, because it can sometimes tip us off to a hidden narrowing from an aneurysm in the wall. And then if we've got any genetics that have not been completed, we try to get that done as soon as we see the patient, and hopefully that happens early in pregnancy. I think that the best care of EDS, as much as I think I'm reasonably fabulous and very humble, I don't think this is something I want to take care of just by myself. We really work closely with genetics. As a matter of fact, the way I got involved in the EDS convention a couple of years ago is Brad Tinkle was our geneticist at Children's, and we worked together with this condition, and he said, well, we work enough together, you got to come and give a talk. So we spend a lot of time working together. For the patients, obviously, with vascular type or with evidence of vascular dilation, then we get vascular surgery involved. Rheumatology, general surgery, neurosurgery, those guys, not so much, but it's really typically MFM genetics and the cardiology vascular guys. They're the team that we put together for these patients. Cervical insufficiency or cervix that opens up is commonly reported as a complication, but in all honesty, when you look at big studies where there's not a bias for reporting, it doesn't seem like it's as much of a problem as the case series reports. So I don't think we have a real answer for that. The challenge is that I'm not a big fan of cerclage in the EDS population, simply because when you do look at the people who've tried to treat it, because of the high rates of ruptured membranes and preterm birth, we don't tend to get as much bang for our buck for the risks of surgery. So there's really not a recommendation for cerclage. What we do is we watch patients really closely. We will, in fact, do cervical length measurements because that's a very safe and effective way to identify patients who are having cervical change. And if we find cervical change, rather than doing a surgical procedure that may injure the cervix, we'll use vaginal progesterone, which physiologically seems to have an effect on providing additional support to the cervix. PPROM, ruptured membranes, is just an unavoidable and common complication. Rates are somewhere in the 25 to 50% range. And what I love about this is if we know the baby has the diagnosis, the rate of rupture is higher than if it's just the mom. And so what that tells me is that you've got, if you've got a fetal effect, you've got all the way full thickness challenges to the collagen, whereas if it's mom, it's just on one side of the equation because the bag of water, the membranes, belong to both mom and the baby. And then when we look at affected baby versus affected mother, preterm delivery, in other words, delivery before 37 weeks, more common if the baby's involved than if the mom is the only one of the two with the diagnosis. We do see some growth restriction. However, since short stature is only seen in one of the subtypes of EDS, I'm not surprised that we don't see an issue with growth restriction in most patients who carry a pregnancy with Ehlers-Danlos. The other challenge is because prematurity is such a big problem, many of these babies would have been delivered before their growth restriction shows up anyway, because growth restriction is typically a last month to 6 weeks of pregnancy challenge. I'm a huge fan of beta blockers, and that's probably going to give people a heart attack because it says that it says in all the books, don't use beta blockers in pregnancy. Real honest-to-goodness beta blockers like metoprolol, atenolol, and propranolol control heart rate, and they control pulse pressure, which is a very important thing to protect your aorta. Now, the challenge there is that they probably also have a little bit of an impact on the amount of blood that goes to the uterus. Well, I am totally comfortable, and you guys can yell at me later, I am totally comfortable for patients who've got a concerning aorta to give the baby a little less food every day. It's not going to, it makes maybe a 12 to 20 ounce difference in birth weight at the end of pregnancy in order to keep mom as safe and protected as possible, because heart rate and pulse pressure are what predict the likelihood of a hole tearing in the aorta. When it comes time for delivery, we traditionally try to give patients really nice, dense epidural anesthesia and then deliver them vaginally with like a vacuum extractor. It looks like a plunger. It's a little soft plastic cup. It's less likely to cause tearing for mom. It's less likely to cause us to have to do a C-section, which is a hard thing to recover from. And so we really do try not to have moms have to push, and then try to make the delivery as easily as possible. I do tell people to take some extra vitamin C. The nice thing about vitamin C is if you take too much, you just pee it out, so I don't have to worry about it being too much. And there does seem to be some evidence that it helps maximize the strength and cross-linking of your collagen. And then lastly, fast labor is both a problem and a wonderful aspect of EDS. We had a mom today that delivered after a 3-day induction, and she pushed for 4.5 hours, and she doesn't like me today because I made her be in labor and delivery forever. With especially the hypermobile type, there are a number of case reports of moms who had just a few hours of labor and showed up at the hospital and delivered on their way from the parking lot, which maybe is not the most stylish way that you want to have your baby, but it certainly beats a 4-day induction. But we do have a tendency to, therefore, bring patients into the hospital earlier just to avoid the excitement of getting stuck in traffic and delivering on the roadside. This drives us crazy because I don't think there's a good answer. Vaginal delivery, cesarean delivery, what's the best thing? I don't want to cut an episiotomy because I know that the healing is going to be difficult. The lateral episiotomies have been advocated because it protects the rectum, it protects the perineal body. It's less likely to result in tears that connect the vagina to the rectum. But again, this is just a challenge for wound healing and repair. But I think a medial lateral episiotomy is probably a little bit less likely to have problematic recovery than trying to have a big incision and the risk of incisional hernia, the skin breakdown that happens commonly, and the challenges with extra bleeding because of the fragile blood vessels. We do tend to use more Dermabond, which superglues the skin, rather than trying to put in stitches, just because we seem to be able to get a little less tissue damage with glue, but some of our patients just don't have a belly wall that helps us there. So we try to use glue when we can, but frequently we get stuck having to use sutures even though we'd like to avoid it. Breech is a common complication just because the uterus is stretchy and the baby doesn't get the instructions to become head down. And then, again, because of the relaxation of the pelvic musculature and the pelvic sling, babies don't get the instructions to flex their head and rotate so that their chin is down towards the floor when you're in your delivery position. So face and brow presentations are more common. And once babies get in a funny position, it does tend to increase the likelihood of a longer than normal labor. Epidural hematomas, anesthesia was telling me to make sure I pointed out that some anesthesiologists worry about placement of an epidural because of the risk for bleeding. And then for the patients with vascular type, they have to be very careful about how they do their regional anesthetic to avoid a tachycardic problem or changes in the amount of blood pumped with each heartbeat. I think this kind of goes without saying. The blood vessel fragility and the problems with platelets with EDS create challenges for vascular repair. It also makes it more likely that your arteries figure out a way to communicate with your veins, just because usually they run near each other, and if there's breakdown, then they're going to talk to each other. For patients at risk for hemorrhage, one of the things we can do to make platelets work better is to give a medicine called DDABP. It's actually a relative of a hormone that your pituitary makes, and so it's safe to use in pregnancy. And so we will frequently give it around the time of an operative delivery to help cut down on surgical blood loss. Vaginal deliveries, we really don't need to use it too much because the bleeding from your uterus after delivery is from muscle tone, not from the platelets or blood vessels. It's only if we have a big tear or we have to do a big repair that we would need the usual surgical protection of DDAVP. Many of these babies are diagnosed with floppy baby syndrome. Obviously, they don't have as good a tone if they're affected. We talked about the genetics, and so that's one of the things we just have. By having the diagnosis beforehand, it allows the pediatricians to be more tuned into what to expect at delivery. It's not associated with birth defects. And frequently, affected babies, if they've not had a prenatal diagnosis, they don't get diagnosed right at delivery. I'm sure that many of you at your support groups hear the stories of people who don't get diagnosed until adolescence or even young adulthood. So back to the specific types in pregnancy, this will just be kind of run through these slides. The classic type usually do pretty well during pregnancy. Episiotomy complications are common, so we try to avoid them. These are patients that have a challenge for postpartum hemorrhage because of acne, so we work hard at keeping their uterus firm. But more importantly, we worry a little bit about bleeding from an episiotomy or from a laceration. And I tend to try to avoid putting forceps on just because I don't want to have the extra diameter that may cause additional tears. The vacuum, because it stays within the diameter of the circumference of the head, doesn't really add extra distance to get the baby out. Hypermobility type, no contraindication of pregnancy. The problem is, I'll tell you, they're some of my most miserable pregnant moms. Their pelvic instability and their sacroiliac pain and their knee pain, I just really feel for them. It's tough. But overall, obstetrically, they tend to do well from a baby standpoint. It's just, I think, physically they find it challenging. Pepin and the group at Hopkins have done the best job of looking at vascular type. Like I said, I really worry about this, but the reality is, if you look at it, 167 babies born to 183 and 183 pregnancies. So the pregnancy outcome, not so bad. But look at this. Who on this conference call can recall even one mom who passed away, that they know one mom who passed away in pregnancy that didn't have vascular type EDS, by the way, because that's cheating. But when you look at this, 12 out of 81, that's a huge rate of maternal mortality. That's a number that I just don't like. Uterine rupture is more common, blood vessel ruptures during delivery. But here's what really drives me crazy. Almost half of the maternal mortalities happened after they were discharged from the hospital. So it's not just we need to get you through the delivery process, but I need to worry and you need to worry if you've got vascular type for 12 weeks or so post-delivery before you can really breathe a sigh of relief from that the pregnancy is not going to cause a problem. The risk is 20% for each pregnancy. And because most pregnant moms have more than one baby, the risk is a little bit higher than 20%. I mean, it's a little bit less than 20% plus times 2 for each pregnancy, just because of funny numbers with statistics. Labor is very commonly early, and rupture of arteries other than the aorta, with subclavian, iliac, are problems that we see during pregnancy. The kyphoscoliotic type does offer a prenatal test with ease. Retinal detachment is a problem with our laboring patients, and then the vascular complications. So in conclusion, the vessels are at risk not just because of the EDS, but also because of the hormonal changes that pregnancy creates. We know that the cardiac output increases, which really increases the stress on the wall of the aorta as it comes off the heart and goes over the top. And then, like I said, I really wish there was a magic trick to help with the joint instability and pain that our hypermobile patients have during pregnancy. Kyphoscoliotic and vascular types are very commonly associated with significant maternal complications, and it really does require, for especially these two types, really requires a well-oiled machine and a team of specialists at a tertiary center to try to maximize safety. And I think I will stop there and answer the 12 questions that I see in my list.
Okay, great. Thank you.
Can I
should see the list, and there may be some more coming along the way as well.
Okay. All right, so I'm going to start first with a question, a two-part question. Do you see an increase in symptoms with each additional child, pregnancy or live birth, with patients with hypermobility type, or does it seem to be additive? And then the second, and so I'll answer that first. We see an increase in symptoms of the joint laxity from pregnancy with patients who don't have EDS with each subsequent pregnancy. So I don't think it's additive. I think it's probably geometric. I do expect additional and worse symptoms with each subsequent pregnancy for most patients, and it's probably more of a problem if you've got hypermobility type. And then second, have you seen predisposition towards menorrhagia, dysmenorrhea, fibroids, adenomyosis, or endometriosis? The menorrhagia, which is heavy vaginal bleeding during periods and painful periods, is a well-described problem in patients with hypermobility type. I'm not aware of an increased risk for fibroids from hypermobility type. And by the same token, the physiology of endometriosis and adenomyosis, there's not necessarily a physiologic reason why one would expect EDS to be a cause of more endometriosis or adenomyosis. However, because of the painful periods and because of the heavier periods, those patients are much more likely to be diagnosed and evaluated. And so I think it's more a testing we find it rather than the condition causing it, if that makes any sense. With hypermobility type, what are the chances of passing it on? That's the next question. Because we don't really know the genetic background, it's a little bit more challenging. I tend to tell patients to suspect that there's probably a 50-50 chance of passing it on. But again, there's not a really good, I don't know that there's a good answer for that. The next question as I scroll down through. What recommendations are there for the management of the placenta for someone with type 3, a history of hemorrhage following an early miscarriage? One, I'm assuming we're talking about a planned vaginal delivery. So with a planned vaginal delivery, or with a successful vaginal delivery, I try not to pull on the umbilical cord to try to get the placenta to separate, because we already know the uterus is probably pretty darn magically flexible, and it's more likely to be turned inside out. So what I do is I will, while I'm providing a little bit of tension on the umbilical cord, actually with my other hand hold on to the top of the uterus and make sure that I massage the fundus of the uterus and really get the uterus to contract and squeeze the placenta out, rather than me pull it out with the umbilical cord. So it's really just a matter of making sure you're using the correct hand. The abdominal hand's better than the hand on the umbilical cord. Do I have written material appropriate to provide to caregivers, like midwives, before delivery? I don't personally have any written material, but I'm totally happy to chat with anybody that's got any questions. I'm going to scroll down to there is a question about the Baton scores, and if you've just barely clicked into the hypermobility score, is that hypermobility type, and is it possible to pass it on? Kind of goes back to that previous question. Because there's not a legitimate genetic answer right now, I can't tell you. I'd have to say I think it's possible to pass it on, and because I am a maternal fetal medicine specialist and not a EDS specialist, I always defer to the experts. If they, my understanding is 3 points is enough to get the answer. Have you had a pregnant patient with 3 points, and were there complications? To be honest with you, the patients that come to maternal fetal medicine with the diagnosis typically are the ones with a more severe disease. Patients with a low level of score typically are cared for by their community docs, and to be honest with you, I can't recall off the top of my head a recent patient with a score of 3, but my guess is I've probably taken care of several patients with hypermobility type with low scores, and they probably are the ones that had the surprise tears at the time of vaginal delivery. And yes, I do. My observation has been higher the score, the more likely there are to be tears and challenges with delivery. The joint dislocations with hypermobility type that affect pregnancy, to be honest with you, it really boils down to challenges with ambulation and mobility. It doesn't really have an impact on the pregnancy itself. The bony pelvis protects the baby from your hips, and your SI joint and pubic symphysis are supposed to be flexible anyway, so the answer is, short of falling down and hurting yourself, the joint issues really don't cause a problem directly for the pregnancy. Hypermobility, worry about cervix issues. Like I said in my slides, cervical issues are a challenge because we don't have an easy treatment. I think if someone is going to be, and I don't really think that the data for cervical incompetence are legit. I think it's what we call recall bias in our literature. So what we do is we will follow with cervical lengths. We don't know that we know that we're right. So it seems more logical to do ultrasound on every other week basis from 14 weeks to 25 weeks. And using cervical length, we'll have an idea of whether the cervix is changing. If it gets short, we're not going to put a cerclage in because we know that's contraindicated, but we do have progesterone available if we see a change. So I don't think you really need to worry about it, but if your docs want to worry about it, then admittedly, I'm kind of risk averse. I think it's relatively easy. It never hurts me to do a vaginal ultrasound to measure a cervix, and it's additional information. For C-section for hypermobility type is that they really need to make sure that when they do surgery, that they're careful about making sure they close the wound under as little tension as possible. I tend to put in some extra helping stitches to keep the fascia closed without it being under tension, but there's not a prior preparation. It's just a matter of being very diligent and careful in your surgical repair. The monthly observations, really, for the most part, it's a normal pregnancy from a prenatal care standpoint, except that for our hypomobile patients, they tend to really, like I said, I sound like a broken record, have a lot of issues with pelvic pain and pubic symphysis challenges. And then the POTS or the postural vascular blood vessel, low blood pressure, fast heartbeat things are a bit more problematic and a little bit more challenging to come up with a good strategy for how to manage. So I tell my patients to make sure they drink plenty of water during pregnancy to try to keep that from being a problem, and always sleep with a pillow under one bun so that they don't get supine hypotension. Will an epidural work if I don't usually react to local anesthetics due to my EDS? Obviously, if local anesthetics don't work very well, epidural is a little more likely to not work well because it's the same drug, just in a different location. The good news is that because it's in the epidural space, there's a little less challenge for it to move around, and so I wouldn't write it off as a possibility. And there is a very real chance that it could work, but a lot of patients will. I've had a number of patients not get the same density of block that patients without EDS get. Can you tell me how to diagnose a baby before birth? There isn't a test for prenatal diagnosis of hypermobile type. When you look back at the recording of this, the first handful of slides talks about the genetics of the condition, and if there is genetics available, there is the opportunity potentially for an amniocentesis where we put a needle into the amniotic fluid, take the fluid off, and send it off to do a measure. That's specifically true for the lysyl hydroxylase abnormality. And then I would guess within probably 10 years, the cell-free fetal DNA test will allow the identification without an amnio for some, but there's just not enough patients who've been tested for that test to be validated and used right now. Best way for EDS patients to approach the discussion of family planning. Who should they consult with to make decisions whether it's safe to have a child or advisable? I think that the best way to start is a preconceptional consult, first with genetics to make sure that we're accurate in which type of EDS you have, and then come back to a maternal fetal medicine specialist with that information so that you can talk about the chances of it being passed on, the implications for your pregnancy, the implications for your life after delivery. I will admit that when I was young, which was thousands of years ago, when I had to talk to a patient with vascular type, it was pretty challenging because while I was not completely intimidated with her risks during pregnancy, I felt the need to point out that lifespan for patients with vascular type are substantially different than the lifespans of patients without EDS. And so she needed to kind of make those plans about, in the event that she followed the usual course, who was going to be there for her baby when her baby was in high school, because she might not be, and that's never an easy discussion to have with anybody. And it's not a reason not to be pregnant. It's just a reason to make sure you have that on the table so people can talk about it as a family, do a little bit of role playing and game planning. 4 years since my second pregnancy. I spent 2 months in the hospital due to an abruption. Plus, my knees and ankles were a mess. That is not something out of the ordinary for hypermobile type. Is there any hope ahead? The good news is I think the abruption risk is probably, there are so many other reasons for abruptions and hospitalizations for bleeding that I'm hopeful for your sake that is not going to be as much of a problem with future pregnancies. I can't promise, but that would be my hope. The knees and ankles and your pelvic area, promise you they're going to hurt more with your next pregnancy, and unfortunately, I don't have a happy trick to give you to tell you that that's not going to be an issue. Is it better for an EDS mom to put more time between pregnancies? I think it's always better to have 3, 4, 5 years between pregnancies. It gives you an opportunity to get the previous pregnancy weight off of your frame It allows you an opportunity to rebuild your core integrity. May or may not help you to kind of work on some joint strengthening and stability. I do think it gives you some pelvic stability. So a little bit of time it seems to make a difference, at least for the hypermobile type. For the same reason why you have a lot of discomfort leading into the delivery, it's not surprising that recovery time is extended for patients with EDS. So the answer to that is hypermobile type patients should expect that they're going to have, they're not going to spring back from pregnancy as quickly. Are EDS vascular or non-vascular type patients as likely as Marfan patients to have dissection? So the specific question is dissection from subsequent breastfeeding. That's an intriguing way to word the question. When we talk about Marfan's patients having post-delivery aortic dissection, to be real frank with you, I don't really think of it as related to breastfeeding as it is to the very dramatic changes in circulating plasma volume and blood volume following delivery, and the fact that you lose some of the hormones of pregnancy that are allowing the vessels to tolerate the increased pulse pressures. So yes, there is a increased risk for dissection and vascular injuries post-delivery, like I showed in that one slide, but not necessarily due to breastfeeding, at least from my read of the literature. And I don't think it's, for the non-vascular type, certainly not as likely as Marfan syndrome. I think vascular type EDS has a risk for aortic rupture that's less than, but starts to get close to the rate of patients with Marfan's. Neither of those two groups are at as much risk as patients with Louis-Dietz, which is another Marfan-like genetic condition. Specific risk of the mom with hypermobile type EDS during pregnancy. To be honest with you, my experience has been falling down because their joints are weak and their center of gravity is all out of whack because of the baby. Ankles giving up, their knees giving up, and people falling down seems to be the biggest risk. The good news is people have been falling down in pregnancy for thousands of years, and the baby is remarkably well protected. So it's more scary than it is dangerous. Will the additional joint laxity of pregnancy of hypermobile types pass after they give birth? The answer to that is typically it takes time, but the hormonally mediated augmentation of the joint laxity goes away. So the stuff that happens normally in pregnancy goes away, but it usually takes more work to get the laxity to be less of a problem. And so there are, for some of our patients that don't work diligently to try to work on getting their core back in tune, they do tend to take longer to get their residual effects to go away. Should we be prevented from using alternative birthing methods, such as a birthing pool? Full disclosure, I am a maternal fetal medicine specialist, so this whole birthing pool idea is a puzzle to me. I'm not aware of any historical records that moms have been, that people have found ponds and rivers and streams in antiquity for delivery. And we know that there have been a variety of complications. Last winter, there were a couple of deaths in Houston from infection. England had to shut down their birthing pool business for a short period of time because of drownings. So I, as a maternal fetal medicine specialist, am not a fan. I also am, as crazy as this sounds, I'm not a big fan of hospital beds. meaning I don't break the bed down. I don't put people's feet up in stirrups because I don't see that. I've never been to a museum of antiquity that they had a hospital bed for evidence that moms had babies in the lithotomy position. So I am committed to making this mom's birth experience not so committed to having it happen in a pool. I don't think that having a baby in lithotomy is usually comfortable or necessary. So you can figure out what I really mean to say from that. But bottom line is, I do think you should have your baby in a hospital because of the risk for bleeding. I started 2 midwifery programs, so I'm totally on board with midwifery services. Just not really gung-ho about the poo and stuff floating around in the water after the baby comes out. Just to be gross. Sorry. You guys can yell at me later. Recommend for couples considering having a child that the prospective mother is an orphan and may possibly have EDS. Again, the challenge is establishing a diagnosis to determine whether or not there's the possibility of prenatal diagnosis. Many of the autosomal dominant patients may be the first ones in their family, and so I'm not surprised that they may or may not know or may not have a family history. And so this type of patient that may have a diagnosis would really do well to see somebody in genetics that is an expert in connective tissue disorders to get an answer about their type so that they know whether there's a way, what the likelihood of transmission is and what the risks are. If a mom has EDS, I would assume that donor egg would eliminate EDS. That's only if the program that does the egg retrieval has EDS on their questionnaire to take that out of the population. So it really requires a careful talk with your IVF team to make sure you know that they're going to exclude that from a possibility. And remember, many young women may not be diagnosed, may have the diagnosis but not have a diagnosis at the time that they're young enough to be given up to be involved in the donor egg program. After delivery in patients with hypermobility type, do the joints hurt more due to the increased pain during pregnancy? Again, I don't think that the pain is because of, it's a chicken and the egg thing. The fact that the joints are more mobile because of pregnancy is going to augment the amount of joint problems that you have if you're already hypermobile. And if you have pain before pregnancy, and pregnancy is associated with joint pain in all patients, then there's going to be an augmentation of that discomfort. And then, thank you, Erica, for asking about the vacuum extractor, perhaps one of my favorite obstetric devices. Vacuum extractor came to the forefront back in the mid to late 1980s. They adapted a device that was originally designed for engine mechanics to pull pistons out of engine blocks. I happen to be a lover of trivia. It is a soft plastic cup that uses a vacuum pump to apply a small amount of suction to help us pull the baby out. The nice thing is, because it's a little tiny suction cup, it doesn't develop, it's not a really good tractor. It doesn't allow us to pull hard, but it does allow us to kind of guide and work with mom to help the baby come out. If you've got extra space because you're hypermobile, just that little bit of extra assistance helps the baby come out. But the nice thing is, because it's less round than the baby's head, it doesn't increase what has to come out, and so we don't increase the likelihood of injuries. So I really like it as a tool. EDS and dysautonomia, not just POTS, but neurocardiogenic syncope. Unequivocally, patients with postural orthostatic hypotension and or neurocardiogenic syncope get worse in pregnancy. The floppiness of the blood vessels and the dysregulation of the receptors of the reflex receptors in the aorta are worsened during pregnancy. And so usually it's a big problem around 20 to 25 weeks, and then interestingly, it seems to get better. But yes, I do think that it gets to be a little bit more problematic. The nice thing is that it doesn't seem to have as much of an impact on the baby or the placental perfusion because the system is designed to move blood to the baby preferentially. So moms can feel miserable, and it's pretty scary, but it's fortunately not. It is a symptom. It's not necessarily a risk. By the same token, I'm sure I'm going to get hate mail because it sounds like I'm dismissive. I've had patients have to spend time in the hospital while we're trying to come up with a strategy to help them with their syncope. So it's a very real challenge from a mom's symptom standpoint. So don't hate me for saying that it's a symptom and not a risk, because I'm really just talking from a baby perspective, not from a mom perspective. And I think I have run through the long list of questions.
Okay, great. Thank you for this wonderful presentation. I learned so much. Probably the single topic I've learned the most on. So we really appreciate all of your expertise and your time and answering each of our questions. I know we have very, very interesting and detailed questions from the group here tonight.
It was a really nice group of questions. And I hope I didn't bore you guys too much.
No, not at all. Not at all. I learned a lot. Was there any other thoughts you had in closing?
I'm running through the public chat right now. I apologize. I got distracted.
Oh, sure. We have some people here that said they had sets of twins as well. That had to be challenging.
Exactly. So I think the closing comments I want to make are that with the right team, EDS is a condition that can be managed safely in pregnancy. It does require some open eyes and some honest discussion if you've got vascular type because of the challenges to the blood vessel. And if you're one of the rare patients without vascular type that has an abnormal aorta, you just have to understand that your care providers are going to be very blunt. I view my job as an MFM to take patients who probably shouldn't be pregnant through a pregnancy because that's what they're committed to having done. And I've done a lot of training and I've taken care of a lot of people so that I feel like I've got at least a modicum of skill in helping people through problems. That said, I never want to be accused of encouraging someone with a potentially life-threatening condition to recklessly go into pregnancy. And so I spend much of the preconceptional counseling time for patients with a high risk for bad things to happen, having them hear that I don't think that they should be pregnant, but if they decide to be pregnant, I'd be more than honored to have an opportunity to be involved. And that's where I think I'll leave it.
No, that's great. Yes, the moral is be prepared, be informed, and
information is a very powerful tool.
Right. Super. Well, thank you so much for your presentation tonight. We really appreciate having you.
Thank you.
We are going to have the recording posted on the website tomorrow. If you would like to listen to that again, you can go to the announcement for Dr. Jaekle, and we'll have the link there for you, as well as a PDF of his slides that he used tonight. So thank you, everyone, for joining us.
Yeah, thank you, Dr. Jaekle. And we are really appreciative of everyone that attended this evening, and we got a lot of good information. I'd like to remind people that the sponsor of this program is bodysupportstore.com, so please go out and look at our website, and there are 250 products, various pillows and braces and the like that you might find that would be helpful. Also, our next speaker will be Dr. Brad Hinkle, and that'll be on the 19th. That's in 2 weeks on Tuesday. Also, this is May EDS Awareness Month, so please, if you want to present a activity in your local community, we can help you with that, or if you have a local community activity, we can report it on our site because we have a listing of those activities as well. And if you'd like to get a EDS awareness shirt, they're on our site at bodysupportstore.com for $10. So you're welcome to order those on our site. So I'd like to wrap up our recording for this evening, and again, thank you, Dr. Jaekle and Deanna, and all those that attended our program this evening. So have a good evening.
You too. Thank you.
Good night, everyone.
Good night. Bye-bye.